So we'll give people 2 more minutes, and then we'll start. Okay, I guess we can just get started. Does that sound good?
Yes.
Okay. So once again, the purpose of the study is for patients who have received curative intent prostate cancer treatment. We want to determine whether more frequent PSA testing leads to better survival or more harm for the patient. In order to answer this question, it is important to know every PSA test the patient had. We want to know exactly how frequently a patient is having PSA tests and to know if the patient has had a recurrence. So we're thanking you for asking all the questions. Many questions relate to, is the patient eligible? What if you can only get some records for a patient but not all the records? Or what if the PCP's office responds but the urologist's office will not respond? The key question is, do you feel you are able to record all the PSAs a patient has had after treatment? So you will need all the office records. And if you feel you have all of the PSA tests, then that will be a complete set. So the eligibility criteria questions are, is there evidence that medical records are available for the patient for 5 consecutive years or until distant recurrence or death, whichever is first? For patients who receive primary radical prostatectomy, the patient's urologist and primary care physician can be identified. And for patients who receive primary radiotherapy, the patient's radiation oncologist and urologist and primary care physician can be identified. The patient has had at least one PSA test result within 2 years after the end of primary treatment, and the registrar is confident in capturing PSA information for 2 years after primary treatment completion. So on the eligibility questions, if no is selected on the first question, the second question will not show up on the web form. And if no is selected on the second question, the third question will not show up. All 3 questions have to be answered yes for a patient to be eligible. We had been getting some emails that people were only seeing one question of the eligibility questions, and this is because all 3 questions have to be answered yes for a patient to be eligible. So for PSAs, we need the patient to have 5 years of complete information on PSA. And that is for the patient to be eligible. But once they're eligible, we are asking that you collect 8 years for the surveillance period. It is possible that the patient did not have a PSA checked every year. Registrars should follow the Ford's manual. For example, for a PSA of 1.2, the registrar can enter 0, 1, 2, or 12 numerically. These are identical numbers and will not affect the study or data analysis. When a patient has a result of less than 0.03 or less than 0.01 or less than 0.2, less than any number, we would prefer that you enter the result as 0 for this special study only. In this sole instance, we differ from the Ford's manual, and the example was given in the instructions to specifically show this. So for scans that are clearly not related to prostate cancer or prostate cancer recurrence anywhere in the body, they do not need to be entered into the web form. If you're not sure whether a scan should be entered, please err on the side of entering. For radiation planning scans, CT usually, enter the radiation planning CT scans as other for indication of study. Recurrence, we have defined local, regional, and distant recurrence in the manual, but we've also put them on this slide just so if people have further questions. So local recurrence is defined as recurrence in the prostate or prostate bed. This is defined by biopsy of the prostate or prostate bed and pathology from this biopsy showing recurrent prostate cancer. The date of local recurrence equals the date of this biopsy. Alternatively, if biopsy is not done or information is not available, the local recurrence in the prostate or prostate bed can be defined using imaging. So the date of the local recurrence would be the date of the imaging scan. Regional recurrence. So regional nodes are nodes of the true pelvis, which essentially are the pelvic nodes below the bifurcation of the common iliac arteries. They include the following groups: pelvic naus, hypogastric, obturator, iliac, internal, external, and naus, sacral, lateral, presacral, promontory, geratas, or naus. Distant recurrence or metastasis is recurrence that is not local and not regional. So if you have a question on recurrence, these are the definitions on local, regional, and distant recurrence. For radiation dosage, please remember radiation dose is collected in units of gray, not centigrade. So example, a patient received 6,660 centigrade, which converts to 66.6 gray. So please round to the nearest whole number. So it would be 67 gray. Page 82 of the instructions document states the allowable values are between 1 and 200 gray, and then the additional 0, 7s, and 9 options for no and not unknown. So we've had some questions on how to code the NCDB radiation therapy. This actually is a variable that is defined by the NCDB, so it's actually not in the Ford's manual. So we are giving you the codes here to code if you need to make a change for radiation therapy. And this can also be found at ncdbpuff.fax.org. So this is what you should be using for coding on the NCDB radiation therapy. So we want to clarify the instructions for special study versus Ford. All instructions in the special study instructions document are for the special study only. Ford should be used for routine data collection for the NCDB. Specifically, the instructions for coding biochemical recurrence and patients who are never disease-free instructions differ from the Ford's definitions and are only for the special study. So, for example, in Ford's, patients who are never disease-free should be coded as 11, and for the date also coded with zeros, and never disease-free is technically the same as no recurrence in Ford, but for the special study, we are calling never disease-free as having a recurrence, and the date of recurrence should be the first date of the PSA after the primary treatment. Also, there are many options for the type of recurrence in Ford's. Ford's gets very granular for the study. We are only defining local, regional, and distant recurrence. So, for example, there are 13 different codes for distant recurrence in Ford's, and for the study, all distant recurrence will be under one definition. So there is a slight difference in the special study instructions versus the Ford's manual. Do not update the NCDB with recurrence differences from the special study definition. We realize that this is different from Ford's. If you find a patient has had a recurrence by Ford's definitions and that recurrence was not previously recorded in the NCDB, please update the patient's NCDB record with that information. Some registrars were having issues with the display of the additional clinical information tab. This issue should be resolved now, and if the problem persists, please email specialstudy@fax.org. We do not have the capabilities to allow for printing or sorting patient lists, and we suggest taking screenshots. So for study communication, we have the special study website and the Cancer Forum and Standards Resource Library. We'll be posting all of the announcements and recorded webinars and PowerPoint slides there. So on both of these, the website and the Standards Resource Library. Please send all study-related questions to specialstudy@fax.org. The study-related questions sent to personal fax accounts will be forwarded to the special study address and a ticket will be created. So either send us an email through the contact form of the website or email the specialstudy@fax.org email address. Please do not send both, as all emails go to the same account. We ask that you include FINs in all your communications so we can get the most specific information to you. If anyone you know is having problems with the emails, emails for the special study are being sent from specialstudy@fax.org email address through an outside server. If you have not been receiving the emails, send the following information to your IT department and ask them to put us on the whitelist. So, and here is a list of all of the webinars so far. So we've had 5, and they're all worth 1.0 CE. Questions from previous webinars and the Cancer Forum will be included on all webinars. Frequently asked questions document will be posted on the website and the Cancer Forum and the web form. So here is a little screenshot on the website where the frequently asked questions document is located right under instructions and resources. And that's on the first page of the website. So now we'll review some of the frequently asked questions from previous webinars and from emails that we've received to date. So Gleason score versus pattern. When you're asking for the primary biopsy Gleason score and the secondary biopsy Gleason score, are you really referring to the primary and secondary pattern? So the answer to this is both the score and pattern are used and meant to describe the same thing. So in this case, primary biopsy Gleason score is 4 and the secondary biopsy Gleason score is 3. So we are looking for the pattern. What should be documented when a physician states a biochemical recurrence? Please mark this as the date of first recurrence by any method. Local, regional, and distant recurrences have specific definitions in the manual as described on a prior slide. What should you do if a physician's office does not respond to record requests? If the record request form was faxed, please call the office directly to request the records and make sure to send the letter template for patient information from the COC so the office is aware this data is required for COC accreditation. For additional clinical information, there is a question about perineural invasion was reported on the prostatectomy biopsy pathology report, but not mentioned in the surgical prostatectomy pathology report. So on this form, please code perineural invasion as no. Only the surgical prostatectomy pathology report should be used. If the urologist and PCP are retired, please see if possible to collect the records from their offices. Often physicians may have retired, but records are still available. All NPIs are required for each provider. If the NPI on the surveillance tab is unknown, please enter 0s if there's no provider, 9s if they have the provider, but the NPI is completely unknown, and 7s if it's unknown whether they have this provider. Comparing the information the NCDB tab has for a patient to what the medical record contains, there's more information available in the medical record than was initially abstracted. So we're asking that you please select no and fill in the updated information. We're looking for the most current data. So what PSA level should be used to classify a patient as having a recurrence? We are not asking registrars to interpret PSA results. please record recurrence if the clinical notes indicate recurrence and/or if the patient receives treatment for recurrence. Does the patient have recurrence if he was never disease-free after treatment? Yes, please record the date of first PSA test after primary treatment as the date of recurrence, and this is for the special study only. Should biopsies and polypectomies from the surveillance colonoscopies be coded? No. As previously stated for imaging scans, please only include biopsies related to prostate cancer or prostate cancer recurrence anywhere in the body. We will be updating the instructions with these changes, so just like the scan tab, only record biopsies related to prostate cancer or prostate cancer recurrence anywhere in the body. So now we will just be answering all your questions that you had.
Eileen, this is Ron. There is a question, there's a slide showing the different types of radiation. Can you go to that slide?
For this one, the NCDB radiation therapy.
Right, and can you go to the slide before that? Okay, go down, so go to your next slide. I'm trying to figure out, so I'm sorry, I was trying to answer questions. I didn't hear what you said. So what were you saying? What was the purpose of this particular slide?
So people have been asking how to code the radiation therapy number, which is NACER number 1360 on the NCDB tab, and we've realized that this variable is not in the Ford's manual, and it was actually a variable that the NCDB created.
Oh, I see. Thank you. So the question that was asked was for patients who receive proton beam radiation, which one of these codes it is. And so thank you for that. So the proton beam radiation would be coded as 1, which is beam radiation, even though the word proton was not in the definition.
Great. So there was a question about collecting total testosterone not free or bioavailable. So testosterone / male, and that's MALE. So that also means total testosterone. So if there's from the surveillance state with 2 years of data and the patient expires, this patient would qualify if you have the complete data before the patient death.
I think there's a question. I think you have a slide on this. If a physician has retired and there's no MPI number, do you still have that slide on this particular presentation?
Yes.
There we go. Thank you.
So if the physician retired or you can't find the MPI number, please enter the 0s, 9s, and 7s options. So if you are to gather all information from all 3 providers for PCP urologist or radiation oncologist, then only report each test or event one time. In the case all 3 send back the same test. If you accidentally enter the same test more than once, we can remove that in the statistical analysis. So you don't have to worry about entering tests as duplicates or triplicates. So you're only supposed to collect 8 years of data from the surveillance start date, nothing before the surveillance start date. And so nothing before the surveillance start date is required in the data collection. So once you enter no to an eligibility question and submit the case, the replacement should automatically be added onto your list. You should try refreshing the screen, and then you should see the patient. If no patient is auto-populated, then please email specialstudy@fax.org because you might not have enough replacement patients. So if you have 2 cases that do not qualify and you haven't gotten the replacement cases, you either don't have 12 patients at your site, or you either have to just click no and then submit and refresh the page, and then the replacement cases should auto-populate. If they don't, then please email us. So all of the slides are available offline. They're available on our website and the Cancer Forum. So you should definitely wait to see if you have all records from the PCP offices to make sure if the patient is eligible. So we have created the frequently asked question document, and it has been posted on our website. So if you haven't got any response from urology or the primary care physicians after multiple attempts, then you can mark the patient ineligible. We need all follow-up information from all providers for a patient to be eligible. So for PSA, you should round to 1 decimal point, so 7.96 would round to 8.0, but you should enter 880. So if you have several patients with at least 5 years of consistent follow-up with the PSA from the urologist, and you have contacted the PCP, but the records are no longer available, those patients are not eligible because we could be missing PSAs checked by the PCP.
I think there's a request, there's a question for you to show the slide for the website.
Oh, sure. So if your facility has less than 10 cases selected that don't meet eligibility due to not having the complete records and there's no replacement records available to assign, your facility would be rated as compliant for standard 5.7 if your site has less than 10 patients and if these patients may not meet the inclusion criteria. Proton beam counts as radiation treatment. So for local recurrence, if a patient doesn't have a biopsy of the prostate bed or imaging, but the PSA is increasing and the patient is prescribed radiation, is this not a recurrence? There's no actual statement of recurrence by the physician, but subsequent treatment is given. So this is considered a recurrence, but it's not a local recurrence. If you see that there's treatment given, then that would be for the recurrence. So for a PSA of 0.38, per the Ford's manual, PSA is rounded to 1 decimal point, so 0.38 rounds to 0.4, so you should enter 4 for the PSA value. We only want scans during the surveillance period, which is defined on page 3 of the manual. So the surveillance period starts after the end of primary radiation treatment and the date of the prostatectomy. Patients are eligible if they do not have a PCP, but we want to make sure that you have all of the PSAs from the other providers. So if you only have 6 cases, and of the 6 cases 2 are eligible, then we would want you to please complete the 4 cases that are eligible.
And then there's a question to see if you would be willing to go back to a slide that shows the NCRA CE number.
Yeah. So if there's a biochemical recurrence per the physician with no imaging or biopsy but does receive subsequent treatment to the prostate bed, would this code as a local recurrence? No, this would not be a local recurrence. Local recurrence is only per the definition in the manual. In this case, the patient should be coded as having a recurrence but not local recurrence. Is there a place to enter the date of death if the patient expires? Yes, use the date of last contact or death field on the NCDB clinical information tab. So there's 1 credit for each webinar that we've had so far. So if any patient has care at the VA, they are not eligible. So if you've already marked them as eligible, please email us and we will get you a replacement patient. And if you have, or else just mark no that you don't have the available records, and that's why the patient's ineligible. We can go back to the recurrence definition slide.
Yeah, this is Ron Chen here. So the reason we wanted to discuss this specifically is to clarify, and there's been some questions related to this. There are obviously situations when the patient has had a rising PSA and then the physician's note says the patient has a recurrence because of that. So because the physician note has said so, then the patient should be coded as having a recurrence. So there is a question on the web form to see if the patient has had a recurrence, and the answer to that will be yes. But a patient having a recurrence, that patient may not have a local recurrence or a regional recurrence or a distant recurrence. For the local recurrence question, the patient will be coded yes if they meet the definitions for local recurrence in the manual, and it's also on the slide. And the patient having a regional recurrence will have to meet the definition in the manual for regional recurrence, and patients having a distant recurrence will have to meet this definition. So some patients may have a recurrence, but may not have a local, regional, or distant recurrence, and that may actually be a pretty common situation.
When you submit a case as ineligible, they should populate immediately once you refresh the screen. So if they're not, email us and we'll confirm if you have enough replacement patients at your site. If you don't have the documentation for intended total duration of hormone therapy, please use 999 or if the duration is unknown, and that is on page 36 of the manual.
Eileen and Amanda, there's a question here that I don't know the answer to. So if there is a patient who received prostate cancer treatment at a facility, and let's say all the physicians, the primary care, the urologist, are all at this facility, but the patient receives some other care at the VA, maybe not related to prostate cancer, would that patient still be eligible for this study?
If the follow-up was done, if the follow-up for the cancer was done at their facility, I think that the patient would be eligible. We just can't have VA facilities participate due to our agreement with the NCDB. However, if we don't need that follow-up information from the VA, if it doesn't pertain to the prostate cancer, then I think that patient would be eligible. Hopefully that makes sense.
So we strongly advise you use the COC letter to outside providers for the study. Requesting records from other providers is very common. So if you're sure that a urologist has captured all of the PSAs checked by the PCP, then the patient can be eligible if you do not have the PCP records. So if you have a patient with a biochemical recurrence who went on Lupron and had a bone scan but did not have a biopsy or CT, would this be local recurrence? This patient had a recurrence, but this patient did not have a local recurrence. The definition for local recurrence is per the manual only. All of our announcements are posted on the special study website and the cancer forum. If you do not have 12 eligible patients, you will still be compliant in the study. So if you're 100% sure the patient does not have a PCP, then the patient can still be eligible if you have all the records from the other providers. If sending the letter doesn't help get the records, you could always ask your committee chair and or cancer liaison to reach out to the practices. They may have relationships established with the providers at the outside institutions. So if you have a patient who had regular PSAs during the surveillance period except for year 6, and they were scheduled for a PSA but did not have it done, and then they returned to the scheduled PSAs afterwards, that is okay. That means you still have a complete set of PSA info. So the patient's still eligible, and just because the patient didn't come back in year 6 doesn't mean that they're not eligible if you have all the records.
Eileen, can you flip to the slide that shows where the previous webinars are stored?
Well, they're all going to be stored on this website and the Cancer Forum, Standards Resource Library. I can pull up here's our website, and then here's where all the previous webinars are down here. And then these are the PowerPoints next to them. So this is the special study website, and then we have the webinars down here, and then the PowerPoints next to it, and we will post today's webinar later today. So there's no code for not local, regional, or distant recurrence. There is the option for date of first recurrence by any method, and that's where you would enter a recurrence if it's not local, regional, or distant recurrence. If there's no biopsy or imaging, then this does not meet the definition for local recurrence. If you can have a recurrence but not a local recurrence if it doesn't meet the definition. The date of recurrence would be in the physician's statement. Your sites would still get credit if you only have 6 eligible patients. So patients who do not have a PCP are eligible. If a patient has a PCP but there's no records from the PCP, then they are not eligible. So you would need 5 years of complete records to pass through the eligibility criteria, but once the patient is eligible, please enter 8 years of data for the surveillance period. The surveillance period for capturing imaging scans, PSA, and other tests is 8 years, and we ask that the patient have 5 years of medical records for eligibility. So complete records, what we mean by that is to please obtain a complete set of records from the physician's office. It is possible the patient may not be seen by the physician every year, but we want to just make sure that you have all of the documentation of all of the physicians that the patient has seen. The deadline for the study is July 24th. We need to know all of the PSAs the physician checked and the scans done and the medical notes. So we have not previously stated the deadline, but the deadline would be at 11:59 p.m. Central Standard Time on July 24th. If you have 5 years of records but not 8 years of records, the patient is still eligible. The 5 years is the eligibility criterion. After you enter all the data on the web form, then you do not need to keep the records.
There's a suggestion that was typed that there's been a few questions related to how to code recurrence and local recurrence and data recurrence. And the suggestion from the registrar is once somebody goes to the web form to look at that screen, some of this may become clear. Thank you for the suggestion.
We can't actually pull up the web form because it has patient information.
I'm sorry, I don't mean we do it. I meant perhaps the registrar could do it on their own website.
Okay. So there's a question, the two physicians in the same medical group check the patient's PSA. Do we list both physicians and their FINs? Yes, I think by FINs, I think you mean NPI. But yes, we would like both physicians and PIs. So if the patient has a PCP, you need to get the PCP records. If the patient does not have a PCP at all, then the patient would be eligible if you have all of the other records. So I think I've gone through and read all the questions that people have posted today. The definition of primary care physician can be found in the instructions document. So if you have 5 years of medical records, the patient is still eligible. So if a PSA value is 0.19, would that be coded to 0 since it's less than 0.2? No, since you have the actual value, that should be rounded to 0.2 and entered as 2. The examples we gave were just less than some numbers. So if the less than is in front of any number, then please mark 0. But if it's just, if you have the exact value, we would like you to enter the value. So a primary care provider can include a physician assistant or a nurse practitioner.
And that's also defined in the manual, so that's not something new that I'm saying.
You can consider a patient complete and submit if you have entered the complete information on the patient. So can you use a PSA if the MD says the PSA was less than 0.1 in November 2011, but you have no lab report? That is okay to enter, and you can still enter that. You do need to know if the patient had a PCP to be eligible. If there's any follow-up treatment for prostate cancer done at the VA, they would be ineligible because you would not have access to those records. All right, everybody, I think that's 12 o'clock, so our time is up on answering questions. If you have any further questions, please email specialstudy@facs.org. And we've also posted the frequently asked questions document on the website. So we will see you next week.